start करो. Good evening friends, and welcome back to the Thursday evening PG teaching session brought to you from Sion Hospital, Mumbai. We once again thank the authorities at Sion Hospital, Dr. Radha Gildial, Head of Department of Pediatrics, and the Dean of Sion Hospital for allowing us to conduct these classes here. And we thank Aristo Pharmaceuticals for giving an educational grant to enable a live webcast of these classes. Today again we have two cases. The first case is being presented by Dr. Shweta from Hinduja Hospital, Mahim. So Shweta will start.
Thank you, sir. So I am presenting a case of 14-year-old male child, only issue of non-consanguineous marriage, residence of Malad, Mumbai, brought by parents whose information was reliable, with chief complaints of floppiness observed since birth and not achieving age-appropriate motor milestones, which noticed since 6 months of age. Since the history is significant, I would like to start from birth history. Antenatal, mother was married at 25 years and conceived this child at 28 years. First trimester, she was a registered case of pregnancy, taken regular antenatal visits. No history of any fever, rashes, lymphadenopathy, drugs or radiation exposure. First antenatal scan was normal. Second trimester, quickening was felt at 16 weeks and anomaly scan at 20 weeks was normal. No history of hypertension, diabetes, thyroid disorder or seizure disorder. Third trimester, fetal movements were perceived well. History of polyhydramnios were there. Intranatal and postnatal, child was delivered at full term by LSCS in view of hand presentation and obstructed labor. Birth weight was 2.9 kg. Baby did not cry immediately after birth, required bag and mask ventilation and then was put on ventilator for 15 days. And later some oxygen support by prongs was given for 1 week. He also had a right arm fracture at the time of birth. He had feeding difficulty in form of poor sucking efforts, so hence was given spoon feeding, which he was taking well, and activity and cry was good as per relatives. Parents noticed looseness of the muscles since discharge and they were asked to follow up after 3 months. They also noticed to have a hyperextensible fingers and extra movements of the joints. Although baby was active, alert with a good cry, there is no history of seizures in postnatal period, no contractures at the time of birth, and no history of drooping of eyelids noticed. Development history, gross motor, head control was achieved at 5 months, rolling over at 7 months, sitting without support at 11 months and standing without support at 18 months, walking with support at 2.5 years, but independent walking only on flat surface achieved at 4 years of age. Child was not able to climb upstairs without support till age. Fine motor skills are appropriate for age and he is able to write properly. Language and social milestones are appropriate for age. Child is studying in 8th grade and he has a good scholastic performance. He was provided bilateral hip spica at the age of 1.5 years for keeping the hip joints in position. He was able to walk independently on the flat surface 4 years onward with shuffling gait while shoes on. Not able to climb upstairs without support. Child needs assistance in getting up from the supine position. Is able to sit without support once made to sit. And he takes time and support while attempting to stand up from the sitting position. He can, although he can write with good handwriting. Since last 3 years, parents noticed he was avoiding walking without support and later he was not able to walk at all. He was progressively worsening motor milestones. He was wheelchair bound since last 2.5 years. Parents noticed abnormal curvature of the spine, which was gradually increasing, and weakness also gradually progressed over the last 3 years, and he required support while walking and later was not able to walk at all. Not able to get up from the supine from sitting position. He is wheelchair bound since last 2.5 years. Parents noticed history of bedwetting at night since 3 years, which was achieved previously appropriate age. There is no history of seizures or behavioral abnormalities, no history of abnormal involuntary movements, no history of cranial nerve involvement, no history of imbalance or fall to any side, no history suggestive of sensory system involvement, no history of urgency or incontinence of urine, no history of increasing weakness as the day progress or diurnal variation of weakness. Child is immunized with all the routine and optional vaccines till 10 years of age. Family history of some muscle disorder in maternal uncle is shown in this chart. Diet history, he was on expressed breast milk with spoon feeding for 6 months, and complementary feeds was introduced at 6 months of age. He eats from the family pot, 24-hour recall method, calorie deficit of 800 kilocalorie and protein deficit of 15 gram. A child can have solid food also, but take time to finish the meal. Socioeconomic history, he belongs to upper middle class as per the modified Kuppuswamy classification. Okay.
Okay, so what are your initial thoughts with these chief complaints? Floppiness since birth. So, what is your broad categorization of a floppy baby?
So this means history of floppiness since birth. So mostly we are looking at some congenital. Is it some central or peripheral cause for the floppiness?
Okay, so you want to divide it into central or peripheral. Further, see what I am trying to say is that parent has come to you that baby is floppy since birth. So now you have to start thinking and then start asking your further questions on history, right? So you should have your initial broad categorization. So you said central or peripheral. Anything further in that? So in central what, in peripheral what?
Sir, we can actually categorize broadly into cerebellar and spinal cord and root pathology or nerve pathology.
So which is what
pathology.
she said, central and peripheral, or you can say upper motor neuron. So now is it upper motor neuron?
No. Lower motor neuron.
So when you have a floppy baby with a central cause, is it a upper motor neuron disease or no? It is a catch question, so you'll have to think carefully and answer. Come on, anyone.
So for that we have to ask further questions to ruling out central or peripheral, like whether milestones are achieved, all the milestones are affected or only motor milestone is affected, any history of seizures or any behavioral disorders.
Yeah, all that you use as associations to decide upper or lower. So which brings me to the point that upper motor neuron and lower motor neuron pertains to whole CNS or it pertains to a particular part of CNS? What's your answer? Huh? Which part?
Alpha motor neuron.
Motor system. So pyramidal tracts. So upper motor neuron is pyramidal tracts and after the anterior horn cell is the lower motor neuron, right? Going back to your floppy baby with a central cause, how do you know that a given baby who's hypotonic, the cause is central or peripheral? How does a clinician decide?
In central hypotonia, the power is not affected.
Very good. So in central hypotonia, power is not affected. So then is pyramidal tract affected? There is no involvement of pyramidal tract, no. So the point is central hypotonia, whatever are those causes, they don't affect the pyramidal tract or the motor system. So your question of upper motor neuron or lower motor neuron doesn't arise in that sense. Okay. Now, so one was central peripheral. Any other thoughts on this slide? Then you have to extrapolate it to being a 14-year-old and then take it further.
Again, the peripheral also could be divided into what?
Yeah, all different segments of peripheral. Sorry, you want to say?
I think by and large a floppiness at birth is always a peripheral till proved otherwise. But because if it is severe hypotonia is different than complaints of floppiness. Two things are a bit different. Okay, somebody may be hypotonic where it's not equivalent to floppiness. Hypotonia is a clinical examination finding. Floppiness is really an observation. Okay, and to that extent, floppiness, the first question would be whether the baby is able to move the limbs or not. So is it a problem of a loss of power and tone, or is it only the loss of tone and not the power? That's the first difference. Central cause is rare to be noticed as floppiness. Central cause would be noticed as a severe delayed development, seizures, whatever. And a hypotonia or a floppiness may not be even complained of. So when floppiness is a complaint, it's peripheral till proved otherwise. Now my question is, can there be a good power and still loss of tone? We are talking about loss of power or not loss of power. Do you think power could be normal in this child?
It can be normal in central causes.
So why should a power be normal and the tone be so low? I thought hypotonia and loss of power go together, isn't it? Then why this discrepancy? Any thought on that?
There is equal loss of tone in both the agonistic and antagonistic muscles, so the power is not affected.
So what sir is asking is, what determines tone? Who controls or what controls tone? There is the answer to this question.
There are two entities. There are muscle spindle and Golgi motor neuron, which maintains the tone and reflexes, of course.
Would a cerebellar disease have a hypotonia? And then there would be no loss of power. Correct? Then where is the problem? He's asking which sites in the brain control the tone. One is cerebellum. What others?
Basal ganglia, right? So basal ganglia problems have hypotonia, right? So the answer to this is that primarily it is the motor system which decides tone and power, but supra influences are many. So there are connections from various parts of the brain to the pyramidal system controlling tone. And that is why your severely asphyxiated baby, what used to be called as hypotonic CP, is hypotonic, though it is CP, because all those connections have been severed from everywhere in the brain, right? So there are supra connections which control tone.
So corticocerebellar tracts are involved. Therefore the cerebellar findings are there, but the cortex is also involved. Therefore extensive brain damage would cause a hypotonia. Okay, even when there is cortical damage, because all those lower down fibers are getting upset, and finally therefore the tone is low, mediated through the lower centers, what we are talking about. So now tell me, in this story so far, 14-year-old, let's not bother about the next slide. Okay. Without knowing the next slide, what is your guess? Where is the anatomy of this child?
So now sir already said that if they are coming with this complaint, take it as peripheral. So you said peripheral or lower motor neuron, you want to divide it into your 4 or 5 parts. Which are those parts? And start differentiating between them.
Now I'll add one thing. Appears that the mother who has noticed floppiness would have easily told you that the baby is not moving the limbs. So I imagine the power must be normal or good enough. Okay. So I imagine power must not be affected, may not be severely affected at least, but the tone is affected. Now
You got this point?
Where is the lesion? Power is probably not affected significantly. Some small power loss may be there, but not significantly. Otherwise, the complaint would not have been floppy. Complaint would have been, my child does not move the limbs. Okay, so let's look at how the parents view the problem and which part they put it across to you as a symptom.
Sorry.
Floppiness is your word. What did the parents say? Now we are using medical term for a non-medical term for parents. What did they say? Baby हिलता नहीं है, जरा भी हिलता नहीं है, हमारा baby ढिल्ला है. What did they say?
They said that baby was loose at the time of birth and he was keeping his limbs like in the side only, as a not very as a.
So at that time we really don't know whether this was floppy. We divide floppiness into weak floppy and not a weak floppy. A weak floppy has, apart from floppiness, power which is proportionate to the floppiness. If the baby is very happy, if you suspend the baby like that, the limbs will be dangling like that. While a baby which is not so weak, the muscles will not, the baby will not be dangling. The limbs are flexed, the lower limbs are flexed. So there is a disproportion between the power and the tone. And the power is little better for the given tone that is there. So that is a weak floppy baby is lower motor and not so weak a floppy baby is up. For example, Down syndromes are floppy, but they are not lower motor neuron. So we must first ask what words they have used. So at that time when she said that the baby hilta nahi, I wouldn't be able to make out whether it is hypotonia, it is floppy, non-floppy. This we have used the word and therefore we have come to. So that time we will have to keep our mind open that it could be a weak floppy baby or not a weak floppy baby. And then we will later on conclude that.
But I think, so sir's point is that if the baby wouldn't be moving, then they would say right from birth, hands and legs are not moving or moving less. The complaint wouldn't be loose. So loose complaint means that movement is not so bad, means power is not so bad. So now tell us what, anterior horn cell? Can this be anterior horn cell after this discussion? No, very good. Why?
Sir, because there is loss of, sir, because in anterior horn cell there will be loss of power.
Very good. And
sir, it will affect only a particular segment rather than the entire limbs.
so let's take that further. Which anterior horn cell disease affects a particular segment and which affects the entire body? Come on, anyone?
Anterior horn cells will affect a particular part of the body.
Will affect the?
Anterior horn cells.
Will affect?
Particular part of the body.
In which disease? Name one disease of anterior horn cell.
SMA.
SMA. So SMA affects a particular part of the body?
No.
Whole body, right? So when you say particular part, it is poliomyelitis and whole body is SMA. Two opposite examples, right? So that is one reason you said that there would be paralysis. What else? This was noticed at birth and today the baby is 14-year-old. The child is 14-year-old. So what does that tell you?
And in central cause, the weakness comes later, once the disease evolves, and then later on that can be spastic, evolution of hypotonia to spasticity in cerebral palsy or.
Okay. That is in the central cause. We are just now discussing, can this be anterior horn cell? We have come down to lower motor neuron only on this slide, and we are now discussing which part of the lower motor neuron. So can it be anterior horn cell? The answer is no, for two reasons. One, there has to be paralysis. Here we have got a history of looseness, and someone who is paralytic on day 1 would be progressive and wouldn't last for 14 years. So anterior horn cell SMA is out. Now next, in a lower motor neuron, next what would you discuss? Can it be nerve root? Okay, what else?
This is actually generalized. Nerve root may be a localized cause.
So whatever nerve root diseases that we see commonly are acute demyelinating disorders. They are not chronic like this for 14 years. So nerve root is unlikely. Then you come to?
Nerve fiber.
Okay. So can it be a nerve problem, generalized nerve problem?
Sensory symptoms are not.
So one is sensory symptoms. Second?
It would not be generalized, some particular nerve affected.
Okay. So there would be particular nerves or groups of nerves affected. You have hereditary, spastic, paraparesis, etc. So all those things will have particular groups affected, right? Then next, NM junction. So can it be NM junction?
The diurnal weakness is not there,
And what else?
They would present more with weakness than floppiness if it is an NMJ disorder.
And what about the progress over 14 years of a NMJ disorder that has come at birth? How would it behave?
be an episodic kind of episode. It won't be a continuous episode.
Okay.
Precipitated by some illness or
Okay. So next,
the muscle.
muscle. So possible. So
I think if you had seen the baby at birth, and you would have noticed hypotonia severe, but the baby was alert, okay, looking around, which means that the central cause did not exist. Your first diagnosis would have been a congenital myopathy, straight off. Okay, SMA, there would have been a loss of power. Okay, and therefore, congenital myopathy. Now, if it is severe, then there would be even some lack of power. But otherwise, the first probability would have been a congenital myopathy. And children with congenital myopathy would need ventilation because the respiratory muscles are affected, would need tube feeding because the swallowing is affected. So everything, but the child could be alert. Okay, that would have been the first possibility. Well, if you talk about SMA0, etc., then the cry would have been poor. If the cry is reasonable, that means the power is not lost totally or at least preserved, and therefore the diagnosis would have been a congenital myopathy, till proved otherwise. Okay, so it's a muscle disease. Okay, now when I talk about congenital myopathy at birth, I do not know what is the progress likely. So now the question for discussion is, it could be static, as most of the myopathies are, okay, but do some myopathies are progressive also? I'm not talking about the dystrophies. Muscular dystrophy is also myopathy, okay, but what's the difference between dystrophy and myopathy? Muscular dystrophy is a myopathy. What's the difference?
In dystrophy, the degenerated muscle tissue is replaced by fat or some other substance. So it's a dystrophic change. And muscle disorder, myopathies can be inflammatory or degenerative. So in dystrophy, there is degeneration followed by accumulation of fat in them.
Dystrophy is a myopathy which is genetic, which is progressive, which has an atrophy of the muscles, and further the muscles are certainly getting bigger, that means there is something storage occurring there. Okay, and that's why hypertrophy. And it's progressive. So at this point of time we are not sure, but muscular dystrophy typical may not present right at birth, and it could be localized, and generalized might come up over a year or two picked up, and therefore it's not severe at birth. So severe at birth is myopathy and not dystrophy. Now there is something like a myotonic dystrophy. Okay, and there are some progressive myopathies. Now we will have to look at what do we expect thereafter. And the point is, at that point, you would have had to counsel the parents and say that we will have to wait and watch and see what is the progress likely, and only over time you will know whether there is no. Now, by the time now we see this slide, appropriate milestones are not being achieved. Okay. Do you think it's progressive or static? Myopathies are static. What do you think? Static. Because we don't know the DQ of this child, right?
Okay, now one more means just for thought process. So while it was written that floppiness since birth, but you gave us a immediate history after birth, which was delivered at full term and did not cry and all that, right? So if you dissect, then floppiness from whatever 20 or 25 days when the baby went home, correct? Not strictly since birth. So what my question is, with this history, wouldn't you expect a cerebral palsy type of a situation? So then how do you differentiate between the two? You're getting what I'm trying to say? You've got this history that at birth all this was required, and then after this parents noticed looseness of muscles since discharge, correct? So at that point, is there a way to differentiate between a severe cerebral palsy, what we just talked, hypotonic cerebral palsy, who's so loose because of all this damage, versus the previous discussion which we just had, that it's a peripheral nervous system problem?
So the onset of the looseness of muscle. If the onset,
so we don't know the onset, na? See, onset is baby is delivered, did not cry, put on a ventilator.
That shows the muscle weakness. The muscle weakness must have been since birth. So
yeah, but that's a retrospective guesswork, no? See, after you decide that now the baby's muscles are weak, then you say, okay, babies must not have cried because of weak muscles. But when you get this history, I would first think of CP. So I'm asking you, what is the difference?
So the activity of the child, activity and cry, because if you're thinking of a severely asphyxiated CP, then he will be lethargic or will have neonatal encephalopathy like pictures. But there also in the stay, the child's activity is good, and even at home the parents said that he was active, alert with good cry. So a CP would not be active. And
No seizures.
No seizure. No seizures. So what I'm trying to say is try to correlate the event. So this is a very subtle situation. We are right. We now know that this baby did not cry because the muscles were weak. But it is very easy to take not cry as the primary event and jump to cerebral palsy. But then you realize that there are so many things which are not fitting in, like the mentation and the activity and the absence of seizures and all that, right? Okay. Now,
I think one point at that time one should look for whether the baby was alert. Was this an alert baby on a ventilation, or really a depressed baby on a ventilation? And if it was a peripheral cause, then it would have been an alert baby on ventilation. Okay. And I think that might be one clue to the whole thing, because subsequently you have said that cry was normal. Okay. So
that's what. So mentation alertness is very important at that time. Okay. Now someone to analyze these milestones. Who wants to analyze?
Sir, actually at control is supposed to be at 3 months, which is delayed by 2 months. Rolling over is supposed to be at 5 months, which is delayed by again 2 months. And sitting without support on that.
So your first conclusion is that most of the gross motor milestones are delayed. That's your first conclusion, right? Now, whenever you are approaching any child with delayed milestones, what are the questions that you want to answer in your mind? So one is that they are delayed. Second?
Is the DQ maintained?
Very good. So you want to decide static or progressive. So what do you think here?
It's progressive, sir.
Okay, so everyone agrees or somebody is differing? Progressive. So,
put the DQs everywhere.
okay.
And convince us it's progressive.
Chal, start from the first. Rough, we don't want calculator DQs. So at 5 months you would have said DQ is how much?
60%. 60%.
Okay, 60%. Then at 7 months? So DQ?
70% actually.
60 to 70. Then sitting without support 11 months. Others also pitch in. Chorus answers. You should practice calculating rough DQs. 80%. So it's getting better. Okay, then standing without support.
12 months.
12 ka 18. You wanted at 12 months, it's 18. So it is 66, 2/3. So 66%. Then walking with support 2.5 years.
15 months.
So 50%. Okay. And then independent walking only on flat surface at 4 years.
50%.
50 or even
Lower.
lower. So that's why you are saying this is progressive. Okay, now.
So the point is, it's a slowly progressive disorder. Okay, initially it looked like that there is a delay, but looked like a constant static delay. But as the further complex weight-bearing movements had to come, you started getting a little delay, and therefore slowly progressive muscle disease. So it's a progressive myopathy. Okay, that much we knew by now. Now what type of myopathy, etc., we'll put some label to that. Okay, but right at that stage, we will almost know that this is a slowly progressive disorder. And that brings a question, how early do you diagnose CP? Because you have to be sure it's static. This looks like static. In the first 1 or 2 years, you would have convinced me, oh, static, it's a cerebral palsy, don't worry. And now you are saying it's progressive. Okay. So my question is, how early can you label it as CP? Shall you wait till 2 years, 3 years and say, I've seen one, it could be slowly progressive? What's your answer to that?
Cerebral palsy, it should come with not just a delay in the motor milestones. The rest of the stuff also should fit into the diagnosis of CP. For a child to be only having a motor delay with rest of the milestones achieved appropriately with clinical findings not suggestive of cerebral palsy, then I will take my time to label it as a CP and look for other causes.
So I think the rule is don't label CP in the first 1 or 2 years. Okay. However, if everything has gone the standard way of CP, which means there is a microcephaly, okay, there is a birth injury, okay, then I know that it is. Further, if it is also associated with other milestones delay proportionately less, then I'm sure it's a central cause, whereas this is peripheral. So to that extent, the answer would be, you may announce it at the end of a year or so if every situation is classical for CP. That means microcephaly, birth injury, and also other milestones delayed, other domains to some extent. And if not, then you would kind of wait further and say, let's wait on. Because after all, waiting is absolutely safe. You can continue physiotherapy, etc. But don't label it as CP, because slowly progressive disorder, even cortical, might look like a CP, and this might have looked like a CP, right? Now my next question is, how are you sure at that 2.5 years of age that this is not CP? So you go back and say, no risk factors for CP, maybe head circumference is normal. Now all those would have said, no, it's possibly not a CP and it's likely to be static or progressive. That is what we are.
Okay, now we were talking of milestones. So one, you all said that there is delay, then you said static or progressive. What other question you want to answer in your mind whenever you are looking at milestones?
What all domains are affected?
Very good. So all domains affected or selective domains affected? So let's see next what is there. Okay, so what do you make out of this?
Only the gross motor milestones are affected. So more of the proximal muscle involvement, because the fine motors are achieved appropriately, they have good writing skills. So by and large, the proximal muscles mostly would be involved.
So large muscles are more affected, smaller muscles seem to be okay. That's why the fine motor or writing skills and all are good. And language and social, good. So now you are sure that it is not central at all and it's peripheral, as we've been discussing right from the beginning. Anything else?
For social use, directly a jump to bowel control and bladder control. I mean, you should have come to social milestones, that recognition and stranger anxiety, and they are much more important, independent of physical. You must isolate those milestones in cognitive milestones, which are independent of gross motor milestones. And here we are, you have said it right, but then come to earlier social milestones, and they will give you an idea whether the baby is deviating at that time or not.
Sir, you are perfectly right. Only thing is now it's a 14-year-old. So they may remember only bladder and bowel, and they may not remember the age of stranger anxiety, etc.
I think in a muscle disease, in a male child, you also look whether the testicles have descended or not. Okay, undescended testis along with a muscle problem favors that the muscles are involved in getting the testicle out into the scrotum, and therefore in a myopathic child or a neurological child, you always look at the undescended testis.
So now, Shweta, what does all this mean? I mean, the inference of these observations. So for example, you said needs assistance in getting up from supine position. So what is the inference?
There is a truncal muscle weakness that he is not able to get up from the supine by self, and also from sitting to stand up position. He needs support for that also. But
Okay.
although he can sit when made to sit, so he can balance the trunk, but the
Okay.
tone is not good.
Okay. And why is there the abnormal curvature of the spine now?
Because he is sitting with the support, but all truncal weakness, because of the truncal weakness, the trunk is deviating abnormal posture.
Okay. So hypotonia and weakness of the muscles is leading to a spine deformity. Okay. Fine. Anything else here? Narendra, anything you want to ask? Okay. So now tell us your provisional diagnosis. You can come in.
She has made one sentence. No history of increasing or progressive weakness. Just go to the slide behind.
So that was during the day.
No
As
history of
day
increasing.
progresses.
As day progresses. Achha, achha.
So, sorry, this is 14-year-old male child with 14-year-old male child with significant birth asphyxia and floppiness noticed immediately after birth with preserved cognitive functions, social and language milestones, and weakness being static for 10 years and then progressively increasing gradually over 3 years to limit the activity of daily living without involvement of the cortical functions and sensory involvement, possibly lower motor neuron disease, with predominant proximal muscle weakness with secondary enuresis without recurrent chest infections, possibly myopathy or muscular dystrophy, SMA type 3 rare.
So can you now, after all our discussion, how would you put 2 and 3? What would be your points against them?
Muscular dystrophy would not start at the birth, so it's not likely. And also SMA would not, the SMA which present at birth which will not lead to 14 years of normal life.
Yeah, and that wouldn't be SMA type 3. Type 3 wouldn't present at birth.
Yes.
Fine.
Also, muscular dystrophy is not only, they always belong to a group of muscles. When you see muscular dystrophy, their classification, proximal group or facioscapular humeral. The hallmark of diagnosis, there is one book on only myopathies, and if I were to summarize that book in one sentence, every myopathy has different groups of disorders which is specific for that particular map. All the muscles are not affected and not to the same extent. If you have all the muscles affected there, then it doesn't fit with those typical myopathies that we know.
I think it may be safe to say that initially looked static, but later progressive. Not necessarily first 10 years static and then progressive. It appears that something suddenly went wrong and then became progressive. Maybe the progression was slower initially and even worse thereafter. And therefore it's fair to say that while initially looked static, it was slowly progressive and further progression was evident by 10 years or whatever. So what must be the possible cause? So your first diagnosis is a myopathy? What is the probable cause of myopathy? Okay, you have a genetic myopathy, you have a metabolic myopathy, you have a degenerative metabolic. Okay, so try to give some etiology. Okay, I know that clinically it is impossible, even investigation may not. But what is your guesswork beyond myopathy?
Generally, sir, metabolic myopathy would be precipitated by some illness, or it will be waxing, waning kind of thing. And even mitochondrial myopathy also will precipitate with the illnesses. So can be genetic.
Family history.
There is a family
Yes.
history.
So family history. But now tell me, why there was a fracture at birth? There was a fracture of humerus at
Yes,
birth.
sir.
Caesarean baby. Don't blame the obstetrician. Blame the disease. How do you connect the two?
You said something, no? What was the presentation?
Hand presentation.
It was a hand presentation, so it may have been difficult to bring
So
the
it has
baby
no
out.
connection with myopathy, obstructed there, damaged there already, and then delivered. Yeah.
On general examination, I have examined him in a proper light and exposure. Child is fully conscious, oriented to time, place and person. He is poorly built and nourished. Anthropometry, weight is severely affected, 25 kg with a expected 42 kg and less than third centile. Height is 157 centimeter, which is 50th centile. Head circumference is 53 centimeter, which is normal for his age. And BMI is 10.14 kg per meter square, less than third centile.
Okay, 1 minute. So how do you interpret this? In this child, means you should just say 1 or 2 sentences. Come on, you heard the history.
Weight is affected more than the height. Head circumference. No, height is normal. Weight is affected. Head circumference is normal. So, she has also given a history of hyperextensible joints. So we could be expecting tall stature in this child. I mean, for his age, could be.
What I meant is, first of all, see, we have this habit K 157 for expected 170. So we have this habit that height is affected. So height is not affected. It comes out of our mouth SAE. Because it is within the 2 standard deviations, learn to say it is normal. Second, so you would say interpretation, head size is normal, which was expected based on my provisional diagnosis that it's a peripheral disease. Then you would say height is normal, only weight is affected, which is explained on the difficulty in eating. She said, no, it takes time to eat and swallow. So that is the reason for the weight being affected over such a long time. So that's the explanation which would be important in exam.
On head-to-toe examination, head size and shape is normal. Face is elongated and thin. Eyes, there is no squint or abnormal discoloration. Ears normal in size and shape, no any discharge. No neurocutaneous marker. Chest is funnel shaped. Deformity of the chest and abdomen observed with C-shaped curvature towards the left and notch below the right subcostal angle. Right pelvis appears higher up. Contractures present in bilateral knee, ankle, elbow, wrist and fingers. Bilateral foot is inverted and plantar flexed position and scoliosis of the spine to the left side. So these are the pictures, sir. Sir?
Do you think these contractures made you feel that it's progressive?
Yes, sir.
And it may still be static? Initially everything looks static, thereafter progressive. Do you think the contractures made it? CP also sometimes later on looks progressive because of the contractures. You get my point? A CP is static, but if it's not well managed, the patient comes to you later with all contractures and say, I used to stand, now I can't stand. I used to walk, now I can't walk. You say, oh, progressive. This child has contractures all over. Do you want to revise our thinking and say, oh, we said slowly progressive, initially looks static, later on fastly progressive. Is that real progress of myopathy? Or it's only a contractions and poorly managed child? What is your impression?
Sir, because of the hypotonia and not able to use the limb properly, there can be contracture with hypotonia. So it's not usually not every time the sign of progression.
No, in this case, what do you think? That's what you want.
It is because of the hypotonia, sir. As the child is not using the limb properly and there is a contracture of muscles.
Means what sir is asking is that because the child developed contractures, further motor milestones could not be gained. So the reason is contracture, not the progress of disease.
In fact, a severe contracture in a CP would give you a history that there is a milestone which is lost. Yeah, I used to go upstairs, now I can't even walk. So you will show regression of milestones. But it's not true regression, pseudo-regression. So we'll have to be very careful about it, because when you talk about a myopathy which is progressive, there would be very few, most of them would be static. And to that extent, I thought multiple contractures, possibly not well managed, and therefore. So that puts another question. Why do you do physiotherapy for multiple neurological disorders? To prevent further loss of power? To improve power? To improve tone? What do you do physiotherapy for?
To prevent
Okay,
contractures.
common-
To prevent contractures.
Prevent contractures, yes. And improve power?
No, sir.
Now, when somebody has a stroke, you say, no, do physiotherapy. Okay.
Actually, power can't be improved, so we can prevent further progression and prevention of contractures.
Correct. So, sir is asking that besides preventing contractures, how does physiotherapy help? Why does an adult who has a stroke and is totally paralyzed on day one get some power back after 3-4, grade 3, grade 4 power over time? So what happens?
It prevents like disuse atrophy also if passively the muscle is.
Okay. So one is that the passive movements prevent the muscle fiber from getting atrophied. That is one. So that's not contracture. That's a separate gain of physiotherapy. And then what happens over time? Which helps that muscle fiber to start working?
Sir, neuronal adaptation and facilitation of the nerve conduction.
So the nerves start recruiting different fibers, and their number of fibers which they were managing increase, and that is how they start affecting new fibers, and that's how that fiber gets some function. So all these are the gains of physiotherapy. That's why we do physiotherapy, right?
See, every time you do a physiotherapy, patients expect some improvement in muscle power, and it does occur. But it doesn't occur because of physiotherapy. It occurs largely because the damage starts naturally recovering. If there was a hypoxemic damage, the collaterals come in and start working. The other nerves start coming into play. Okay, and therefore that's a natural recovery. But why we want it is to prevent contractures so that that will not come in the way. But of course, you tell them, oh, go on doing physiotherapy, he will start walking. But it's not physiotherapy that's making him walking. Okay, so take a note of that.
CNS examination, higher mental function, child is conscious, alert, oriented to time, place, and person. Remote and recent memory is intact. Speech and language is normal. Cranial nerve examination. Preserved smell sensation. Visual acuity and field of vision is normal, and direct and indirect light reflex present. Fundus was not examined. Third, fourth, and sixth now, there is a normal range of movement and no ptosis or squint. Fifth now, sensation over the face is normal, corneal conjunctival reflex is present, and no deviation of angle of mouth, no obliteration of nasolabial folds. Child is able to close the eyes tightly and forehead wrinkles visible on raising the eyebrows. Eighth now, the child is able to hear voices and responds appropriately. Ninth and 10th now, gag reflex present, uvula in midline. 11th now, able to turn the head to both the sides. 12th now, tongue in midline, no deviation, atrophy, fasciculation or fibrillation of the tongue muscles visible. Motor system. Posture, child is lying in lateral position with the upper limbs adducted and internally rotated at the shoulder, flexed at the elbow and wrist joint with fingers in a half flexed position. Lower limbs are adducted, internally rotated at the hip, flexed at the knees and ankles, kept in the dorsiflex position, most like windswept position. Bulk of the muscles appear small and bilaterally symmetrical. Both the upper limb and lower limb is almost symmetrical. Tone is decreased in all four limbs with increased range of passive movement around the wrist, elbow, ankle and knee joints. Fixed contractures present in the present on ankle dorsiflexion, knee extension, elbow extension, and wrist and finger extension. Power, shoulder flexion, extension, abduction and adduction 3/5 in bilateral symmetrical. Elbow flexion and extension both 3/5. Wrist flexion and extension 4/5, and finger grasp is good enough. Flexion and extension is 4/5. Hip flexion is 2/5, and extension is also 2/5. Adduction and abduction is 3/5. Knees flexion is 3/5 and extension is 2/5. Ankle flexion and extension 4/5, and truncal muscles is 2/5. Reflexes, abdominal reflex present. Plantars are flexors. DTR, biceps and supinator are absent. Knee absent. Ankle 2+, and no clonus. Sensory, touch, pain, temperature elicited normal. No tremors, nystagmus, no cerebellar signs. Gait could not be elicited. No meningeal signs. And other system examination was normal.
Absent reflexes is a lower motor neuron lesion.
Yes.
Okay. So, what is your comment on some reflexes absent? Not all. Okay. A typical muscle disorder may have a retained peripheral ankle for a longer time, knee is lost. Okay, this child has something of the same kind, ankle is present. So, it is behaving like a slowly progressive or static myopathy. Typically, a Duchenne will have last ankle to be lost. So, I suppose that take a note of those things. But if you had a biceps and supinator absent, would other upper limb reflexes were present? So the point is, are the contractures coming in your way of eliciting? That's more likely, okay, rather than really an absent reflex.
Yeah, so
Yes.
so you must, so instead when you say it is absent, you better put it this way, that I cannot elicit the biceps jerk because of a contracture at the elbow. So you are very clear that it is a contracture which is preventing you from getting that, right? Okay.
Summary. A 14-year-old male child with significant birth history, hypotonia since birth and hyperextensible joints, isolated gross motor delay with preserved cognitive functions, normal social and language milestones without involvement of the cortical function, cranial nerve, sensory function, and weakness being mostly static for 10 years and then progressive gradually over the 3 years to limit the activity of daily living with no diurnal variation of weakness. On examination, there is hypotonia with proximal more than distal muscle weakness associated with muscle atrophy and contractures, reduced DTR with normal higher mental function, no bowel bladder disturbances, possibly lower motor neuron, likely muscle disorder, congenital myopathy only.
So as sir already made the point that sudden deterioration in the last 3 years is more likely to be due to the contractures than the disease suddenly getting worse, right?
Yes,
because first 10 years it was static. So when this deterioration is due to a complication of the original disease and not the progression.
Yes. Thank you.
How will you investigate?
Sir, initially also at the 2 years of age, there was a genetic testing done. At that time, it was normal. And they were suspecting Ehlers-Danlos also because of the hyperextensile joints. But that also was negative. And
What is your comment on that? They were suspecting Ehlers-Danlos because of hyperextensibility. Agreed. You want to say anything which is less likely, not fitting or whatever?
Ehlers-Danlos will not have a gross motor delay,
Very
hypotonia.
good. There could be some delay, but not like such a big delay, right? And also there would be...
Some myopathies are also associated with hyperextensile
Correct.
joints.
Correct. Okay, then?
And then repeat genetic testing was performed at 13 years of age. It was detected COL6A1 gene mutation. They said that it was between the spectrum of Ulrich and Bethlehem. And child is posted child was posted for the scoliosis surgery, and right now the surgery has been completed. This is the post-surgery X-ray.
Those structural myopathies, nemaline core and all, was it one of them? Was a muscle biopsy, microscopic, any of these things? But the structural myopathies can be diagnosed on histology.
No muscle biopsy were performed, sir.
Sir, they've got some genetic diagnosis now, so that's why.
And other things, 2D echo was done. It was suggestive of aortic root dilatation and proximal aorta dilatation. And pulmonary function test was suggestive of moderate restrictive lung disease.
Okay. Good.
Yeah,
Any
you have
questions
presented
or
very
anything
well.
else anyone wants to discuss?
You have presented very well.
What happened to that Madalal uncle? He's alive?
Sir, Dr. Palniraman is asking how to elicit tone when there is hypotonia with contractures. So how to elicit tone? I mean, how to show that this is hypotonic?
I think the history suggests hypotonia in that case. If there is already a muscle atrophy that favors a disuse, okay, and therefore you cannot examine the tone at that point of time because there is already a complexion occurring. But the history certainly strong. There could be some muscles where there is no contractures. You could still demonstrate hypotonia in those muscles. It may not be every muscle or every joint has got into contracture, and that's why at ankle you have a reflex present, so maybe an ankle could be hypotonic on examination.
Palpation of the muscle. In a child like that, palpation of muscle, palpation can be the muscle may have looked in a atrophy, but in a contracted joint that part is ruled out. So wherever muscle is available, palpation of muscles will tell you that it has that.
Short case presentation. 15-year-old adolescent female, fourth by birth order, born out of non-consanguineous marriage, resident of Nanded, hailing from Maharashtra, Matang by community, Hindu by religion, and informant being mother, who is reliable. Child is a known case of thalassemia and taking
Speak
regular
loudly into the mic.
Child is a known case of thalassemia and taking regular transfusions for the same, and came with the complaints of increased transfusion requirement since 4 months, which is 3 to 4 per month, and tiredness and fatigue since 2 weeks. HOPI. Child is a known case of thalassemia and has been receiving regular transfusions since 6 months of age, and child had a significant past history, and child is diagnosed with thal major at 6 months of age. As she had loose stools, yellow discoloration of eyes, and reduced activity since 15 years. And child was taken to private hospital. Upon investigations, revealed low HB and received transfusions. Patient was diagnosed to have a blood disorder, thalassemia, following which patient has been receiving transfusions initially monthly, and then 15 days, and now it's weekly. And at 10 years of age, she diagnosed as hypothyroidism during routine screening and started on Tylenol. And she was non-compliant with medications. And in 2020, that is at 12 years of age, she has increased work of breathing and reduced activity and consciousness, and diagnosed as diabetes mellitus and on insulin since then. Upon inquiry, mother also complains of inadequate height gain, which she noticed 3 years back. She also not attend menarche. And she complains of fever during transfusion since 4 months, which was not there previously. Negative history, no history of any bleeding manifestations, no history of pain or distension of abdomen and early satiety, no history of transfusion reactions, and no history of fever during transfusion previously, and no history of constipation, no history of fever episodes by which the illness precipitates. Drug history, the patient is on Desirox since 8 years of age and started at 500 mg, now at 800 mg. Started insulin from 12 years of age, Mixtard 20020, and now giving isoflurane injection at 14014. And she also started thyroxine at 10 years of age. Initially started at 25 mcg, now at 62 mcg on calcium and folic acid supplementation. ANC and birth history, ANC registered, routine ANC visits done, iron folic acid supplementations taken, scans normal, no ANC complications, no fever with rash, gestational gap was 2 years, and child was full term, normal vaginal delivery, birth weight was 3.5 kg, cried immediately after birth, no history of ICU admission. Immunization and developmental history, immunized up to date, no special vaccines taken, milestones appropriate for age. Dietary history, consumes all food groups equally, mixed diet, calories required and consuming. Required is 1828 and consuming is 1943. Protein is 65 and 67. Socioeconomic and family history, there are actually mom and dad is a farmers who are working, and they has 4 siblings, and 1 is normal and 2 are trades, and 1 is affected. Both parents are farmers by profession, and according to modified Kuppaswamy, it will come under lower middle class family.
Wait, we'll come to this later. So go to your first slide. Okay. So what are your thoughts on this? Known case of thalassemia comes with increased transfusion requirements and tiredness and fatigue.
Increased transfusion dependency is the chief complaint. That could be because of the development of, alloimmunization, or development of allo antibodies because of the previous transfusions. And also 15-year-old adolescent female, so we should be looking for concurrent any iron deficiency anemia because of which could also precipitate the both things.
Hypersplenism. Okay. Fine. Okay,
Some
now
infections
go.
can also cause. Some infections can also cause increased transfusion requirement.
Like?
Parvovirus infection, which causes.
So does parvovirus cause increased transfusion requirements every week, 2 weeks? So how long does a parvovirus infection stay?
Yes.
So what I meant is that parvovirus infection comes more often as a one-time event which causes bone marrow suppression rather than a prolonged thing for 3 to 6 months, and in those 3 to 6 months you keep needing transfusions again and again. That second situation is not very likely, right? Okay. Now go back to your first presentation, meaning So what are everyone's thoughts on 6 months of age? This baby had loose stools, yellow discoloration of eyes and reduced activity, and was diagnosed to have a blood disorder. So what would you have thought of at that time? What would you have found on examination which would have made you suspect a blood disorder? So first talk of the complaints: loose stools, yellow discoloration and reduced activity since 15 days. Okay, jaundice. So 6-month-old baby getting jaundice. So what kind of jaundice is this?
Pathological jaundice due to a hemolytic cause.
But why hemolytic? Means see today, now you know it's thalassemia, so you are thinking of hemolytic. But if you look at a 6-month-old with jaundice, will you first think of hemolytic or you will think of other reasons? Sorry?
It could be infective also.
Could be infective. Now think further. When means what infective causes of jaundice can present at 6 months of age?
Infective hepatitis.
So does infective hepatitis, is that a common age for infective hepatitis? 6 months? No. Right? What else? Which are the other infective causes of hepatitis? CMV, EBV. So how would you classify for practical purposes infective causes of hepatitis? Hepatotropic viruses and other viruses, right? Now hepatotropic we said is Hep A, extremely uncommon at that age, so also E. B, can it be Hep B at that age?
If it is acquired congenital as a congenital, then it will be present earlier, not at 6 months.
So does a congenitally acquired Hep B always present as hepatitis?
No.
Does it present as jaundice?
No.
Almost very rarely. Hepatitis B would be either an incidental diagnosis or then much later when there are, if and when there are complications, right? Hepatitis B causing hepatitis is extremely rare, clinical hepatitis, right? So that, and so also C. So therefore your hepatotropic viruses are nearly out at 6 months of age. So you come to non-hepatotropic. Why is this not that also? Okay, more than that. So think of all your CMV and EBV and all. Think of a classic case of infectious mononucleosis.
No fever.
Yeah.
No fever.
No fever. What else? Do they clinically present with jaundice? They present with all their multiple symptoms, and you may notice a little bit of icterus, or you may find it on investigations, but they don't upfront come with jaundice, right? And especially at infancy, pallor is mistaken as yellow discoloration by parents of the body, of the skin. So first thing you would do is you would probe deeper and decide whether this is really jaundice or no jaundice.
I think the statement that diagnosed as thalassemia major and has jaundice, does thalassemia major causes jaundice? So is it unrelated jaundice? Okay, so thalassemia major has no jaundice. So that's number one. Forget that for a while. Have you seen a child presenting at 6 months of age with jaundice? So it's a funny age for presentation, right? What must be the probable cause? Hemolytic looks unlikely. Okay. So, otherwise, unless thalassemia is wrongly diagnosed and you have a congenital spherocytosis and therefore a jaundice, that's likely. But then here they have said already diagnosed as thalassemia major. So possibly it's not hemolytic. Then it must be hepatocyte. Okay. What hepatocyte at 6 months of age as the only symptom? And there are loose stools. CF? CF affects the liver. CF causes loose stools. What about CF? Out of question. Okay. CF doesn't present with jaundice. CF has hepatopathy coming up late, not common, and loose stools is not. I'm just trying to get you together something. So it is not that. Could a metabolic disorder start at 6 months of age? Metabolic liver disease. Okay, yes. Could start at 6 months of age, anytime pre 6 months, whatever, and you have a galactosemia, glycogen storage, tyrosinemia, etc. Okay, Wilson's, most common metabolic liver disease. What about Wilson's?
Age of presentation.
Never diagnosed at that age. Okay, it takes 3 to 5 years or longer. And therefore that statement looks little unusual. Okay. The other statement that is bothering me is that patient has been receiving transfusion initially every month, thereafter 15 days, and thereafter weekly. So it's not an acute event of last 3-4 months that suddenly the transfusions have increased. Looks like this child has been increasingly requiring transfusions. Okay. And therefore it's not an acute onset that so far it used to be once a month and now suddenly gets every week. Then you could have said some acute crisis occurring, aplastic crisis, parvovirus, whatever. But this looks like slowly worsening. What's the cause of slowly worsening requirements, increasing requirements? So hypersplenism. Okay. Now point is that this event must not have occurred suddenly because you have already got an iron stores causing problems in pancreas, maybe in thyroid, and therefore it's too late for increasing, sudden increasing in blood requirement. So this is typically a chronic hypersplenism coming up with requirements more than that. Had it been an acute worsening, then would it be an acute hemolytic crisis? Crisis can be of two types, no? Hemolytic or aplastic, and in sickle, of course, it could be vaso-occlusive. So what do you think? What's your comment on hemolytic crisis?
Why is this not a hemolytic crisis? Why is the increased transfusion requirement not a hemolytic crisis?
No symptoms of acute hemolysis. There's no complaints of red colored urine. There is no complaint of jaundice now. So there are no complaints of hemolysis clinic symptoms. So that could.
And aplastic crisis is far more likely than hemolytic. Hemolytic crisis is rare, and hemolytic crisis presents with an acute worsening jaundice in a thalassemic. Okay. Thalassemic will not have a jaundice otherwise. Okay. And to that extent, I'm not sure whether this thalassemic had jaundice transient for some other reason, but thereafter there has been no jaundice on examination. So possibly we can just get out of that discussion.
Come, we'll just examine the child. लेके आना बच्चे को.
Now tell us what must be the size of the liver and spleen in this child.
Spleen will be massively enlarged, and liver will also be 3 to 4 centimeter below the costal margin.
So my direct question is hypersplenism related to splenic size? Not. Then what made you say that spleen? What would you say? It's not related to splenic size, right? It's a splenic function more than the size, right? So suppose this child has been getting transfusion now every 2 weeks, every 1 week, well transfused. Maybe whatever iron deposition has occurred, it's fine, but well transfused. So would you not expect no spleen in a well transfused? What is your comment on that? A well managed thalassemia may not be recognizable even by face. Forget the liver, spleen, pallor, etc. May not be recognized. So what's your possibility of palpable spleen, large spleen, no spleen? Give us a thought and justify the statement. Whatever that is, we do not know. Some thoughts on this.
Large spleen.
Come on, yes.
So, large spleen will be there because of increased transfusion. So, increased transfusion will lead to further there will be increased breakdown of the red cells in the spleen, increase in splenic function.
So it's not increased transfusion which is leading to that, but basic hemolytic anemia. So the work of spleen is definitely 5 or 10 times the normal, because it has to keep destroying RBCs again and again. So well transfused doesn't take away the hemolysis which is going to happen anyway, and that is why you may still expect a spleen even in a well transfused child, right? The other component of hepatosplenomegaly is extramedullary hematopoiesis, which will not be there because he is well transfused, right? Okay.
So now somebody come near and first tell us by observation whether this is fairly well managed or extremely poorly managed or an averagely managed child. Come on. Let's make a guesswork by observation. Come, somebody, anyone. Come, doesn't matter. Okay. Come, 2, 3 of you come so that there is a moral support. Okay. Yeah. Come, somebody, one more person. Come, very good.
So she's having hemolytic phases, frontal bossing, and like maxillary widening, overcrowding of the teeth, and stature-wise also she's short stature. The like muscle bulk also is like inadequate, poorly nourished, and
dark pigmented skin is also there because of iron deposition.
So my question would be, poorly managed could be poorly blood transfusion managed, or it could be poorly iron problem poorly managed. What do you think is most likely? So putting the question the other way, is iron deposition caused by blood transfusions? If so, then she is blood transfusion was well managed and iron problem has not been well managed. So what is the reason of an iron deposition? Is it our blood transfusion or is it the disease itself?
Increased absorption of the iron in view of in order to prevent the anemia, and also blood transfusions getting hemolyzed.
So both. Reason for iron deposition is both. So now answering sir's question, is it well managed or poorly managed effect finally, means the effect of whatever treatment she has received, how do you decide that based on your observation?
so maybe initially she was the growth is affected. So, it could be a combination of both, because I mean the hemolytic phases could suggest like poorly transfused also over a period of time. Plus, I mean the other endocrinal problems. So that could be because of the iron overload.
Correct. So both parts are not perfectly managed. That's the point, right? Okay. बेटा लेट जाओ इधर, सर इस तरफ. Put on these lights now.
abdominals.
On inspection,
Come that side so that everyone can see. We'll make a lie down that. Come that side. बेटा सॉरी, एक बार उठ के सर इस तरफ कर, हाँ, पाँव नीचे करके पाँव इधर कर दे, हाँ, वेरी गुड, थैंक यू. थोड़ा नीचे आ जा, हाँ, थोड़ा और नीचे आ जा, थोड़ा नीचे सरक जा, वेरी गुड.
on inspection, abdomen is distended, which is diffuse distension. You can see the lump also in. You can see lump over here in left hypochondrium, and umbilicus is normal; it is not everted. The flanks are not full, and no veins are visible.
Upper abdominal or lower abdominal? Distension?
Upper abdominal, more so in left hypochondrium.
Palpate.
The liver is palpable, 3 to 4 centimeter below right costa margin, which is non-tender and which is smooth and borders around, and which is consistency is soft. Consistency is soft.
Soft.
Yes, sir.
So, do you expect it to be soft?
No, it should be firm.
Firm.
And spleen is also palpable, around 6 to 7 centimeter. Notch is palpable, which is non-tender again, and consistency is firm.
In the liver, once you palpate that, immediately your next sentence should be, you said 3 to 4 centimeters below the costal margin. What about the upper margin?
The span.
So check.
So the span is around 15 centimeters, so it is increased. So hepatomegaly is there.
Any free fluid? Okay. Come. उठो बेटा.
So clinical diagnosis is cirrhosis with portal hypertension. Hepatomegaly firm, spleen very large, chronic liver disease, stunted child, poor in nutrition, perfect. Cirrhosis.
Come on, you want to argue?
So there won't be hepatomegaly and cirrhosis. Like even if the liver is felt, there'll be a nodular texture. And for portal hypertension, there'll be ascites and engorged veins.
Okay. So let's take each of these points. Anyone wants to discuss? Come, you all come. Good.
I'm sure no one has seen caput medusae. Okay, so let's not wait for engorged veins to be seen. I have told you enough. Okay, large spleen, fairly large liver, getting chronically constricted so that the spleen is bigger than the liver. So chronic stage of a cirrhosis. Okay.
Come on, other students to discuss this.
Jaundice may come up later. Jaundice is a late manifestations. See, this is a common argument. Presence of certain symptoms or signs of hepatocellular failure favors that this is liver. But absence doesn't rule out necessarily. If somebody has jaundice, portal hypertension, ascites, well, yes. But if he doesn't have ascites, it does not mean that he has not reached that stage. Okay. So, cirrhosis still stands or it does not?
So,
if you like, let me say thalassemia with cirrhosis. So I'm not asking two separate diagnoses, because you will say, no, she has all black skin there, maybe pigmented, okay, history, some faces, okay, thalassemia with cirrhosis. That's a complication, right? Yeah. So how would you rule out clinically or rule in cirrhosis? Give a thought. It's still possible. I'm sure you start thinking, you will hit on it.
Sir, actually there is no...
Other functions of liver may be affected, like any edema, loss of albumin, or icterus and ascites, coagulopathy, bleeding tendencies. So it's not there in this case.
okay.
Sir, there is actually no skin manifestations which we can say with the evidence that she has cirrhosis, like spider nevi or palmar erythema, blue nails and all.
No, so that's what we were explaining, sir was saying earlier. So all these spider nevi and palmar erythema are seen in older children or adults after many years of liver disease, when there is an imbalance between estrogen and the other hormones, right? So in pediatrics, we are very rarely going to see all this. Similarly, shrunken liver is not seen in pediatrics because again it takes a long time. Nodularity is typically a feature of adult type of cirrhosis. So childhood cirrhosis is not multinodular, so you will not feel the nodules on the liver. So those are not the arguments. So the arguments are that there is almost no sign of hepatocyte dysfunction, the common signs being edema, means hypoalbuminemia, or icterus, or the synthetic coagulation factor issues, and mainly no ascites, which is a combination of hypoalbuminemia and portal hypertension, right? So that is the main reason why this is not a liver disease. Then of course you have hemolytic faces, you have dark pigmented skin suggesting iron overload and all that. About sir's question of thalassemia with cirrhosis, what would be your answer? Think and tell. Cirrhosis is a problem of which part of the liver? Anatomically, which part of the liver? Cirrhosis is hepatocellular, and thalassemia is a disease which affects which part of the liver? Reticuloendothelial, right? So therefore this is not thalassemic cirrhosis.
And therefore there is no cirrhosis. Okay. Whether you want to call it separate entity cirrhosis, you already said no other manifestation, no edema, etc. Yes. But thalassemics don't get cirrhotics. Okay. To that extent, this is certainly that. But thalassemics get a lot of liver diseases. So which liver diseases thalassemics get?
Transfusion associated hepatitis B, hepatitis C virus infection.
On examination book.
General physical examination. General physical examination. Child is lying comfortably in supine position, non-sick looking, afebrile, heart rate is 102, respiratory rate is 24, SpO2 is normal, BP is 104 by 78, central pulse and peripheral pulse is well felt, extremity is warm, no pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema right now. Anthropometry, weight is 33 kgs, which is less than 5th percentile. Height is 126 centimeters, which is less than 3rd standard deviation, for which the median height is 162 centimeters. BBM is 20, and there is actually visible severe stunting, and mid-parental height is 142 centimeters. This is a growth chart that I plotted for that. Both height and weight is less 5th percentile.
What's your comment on that growth chart? Weight is not much affected. Well, it's on the lower side. Height is terribly affected. Why is that? But the weight is below 3rd standard deviation or so, right? So weight is also very low. Why should a weight be low? You have seen thalassemics. Their weights are all right. They are eating well. They are otherwise fine. They only are short. So why is this child so poor in weight?
Nutritional component could be affecting the weight probably because of malnourishment, and height is
nutritionally bad. Does she look nutritionally bad? No.
Nutrition is not major factor. Maybe minor. Yes, something more.
Could her complications have contributed? Insulin, she was on diabetes, no? So there could...
Diabetes, right? But hypothyroid should have counteracted it, no? Also look at HIV, also look at HBV, HCV, whatever. So I think look at treatment related as well as the disease related. So
also please note the height to which the height is affected. If you interpolate it lower down, the weight should have gone so much lower down. Comparatively, the lower weight has not gone down so much. So though statistically or figure-wise you think that she is very much underweight, she is not. In fact, for her given height, she is very good. And maybe with diabetes may produce, just as it can produce weight loss, it can produce a little extra gain in weight also. So also untreated hypothyroidism.
Okay, suppose you were to look at only this growth chart without any history. No history, no findings, only this growth chart. Can this be growth hormone deficiency? Very good. Weight should not be subnormal. Weight should be in the normal range. However badly the height is affected, right? So this suggests...
could it be constitutional short stature? Could it be genetic short stature?
I thought all of you should have shouted no.
Shouted at me, yes.
Come on, come on, come on. Don't take so much time to think for constitutional and genetic.
It should be within MPH range, not very low. And
so they are around the 3rd centile or a little below the 3rd centile, not like minus 10 standard deviations. So that's never constitutional or... 20.2 or something he said.
15 years. Head to toe examination, hair normal, face, frontal bowsing appears, malar prominences, flat nasal bridge, partially open mouth, and oral cavity, crowded and pigmented teeth, no evidence of stomatitis, tongue normal, tonsil, throat, and pharynx is normal. And eyes is also normal, and there is evidence of generalized hyperpigmentation and ill-developed secondary sexual characters, no menarche attained, pubarche, tunnel stage 2. Systemic examination, per abdomen, inspection, no scars, no visible dilated veins, no pulsations or peristalsis, skin or abdomen normal, umbilicus is circular, inverted, central, no swellings, hernial orifices normal. Palpation, temperature normal, abdomen is soft, soft in consistency, non-tender, no guarding or rigidity. Liver 14 centimeters from left subcostal margin in mid-clavicular line, and surface is smooth, margin is ill-defined, consistency is firm, non-tender. Spleen is 10 centimeters, grade 3 of ICATS classification, firm, borders are notched near umbilicus. Percussion dullness noted over liver and spleen. Liver span is 18 centimeters. Auscultation, bowel sounds present, no bruits or murmurs. Summary. 15-year-old female child, known case of thalassemia major, hypothyroidism and insulin-dependent diabetes mellitus, on treatment with newly diagnosed growth failure, non-compliant with medications, with increased transfusion requirement, with hemolytic phases and hepatosplenomegaly is most likely the cause of thalassemia major, complicated by iron overload with improper chelation therapy, most likely due to non-compliance.
Will you also add to the diagnosis of delayed puberty?
Sorry, it may be due to deposition of iron in pituitary, and it
No,
may
not
cause
the cause, as a feature of diagnosis.
Sir is saying just in this you would have added with delayed puberty.
delayed puberty, yes.
Okay. Any questions or anything? Stop. You have any questions?
No, sir.
Okay. Fine, I think we'll stop here. Sir, Palni Raman has made a point that in thalassemia, because of ineffective erythropoiesis, hemolytic crisis is very uncommon, right? Fine. So I think we'll stop here. So thank you everyone. Thank you our online viewers and online faculty. Yeah, Dr. Heman Joshi wants to make a point.
Yeah, you all will become good pediatricians and you will treat couple of thalassemics. But if you make your vision big, you can plan to make India thalassemia free. Make it your life mission.
Okay. So we stop here for today and we meet once again next Thursday at 6 p.m. Again, we invite all other students who are watching us to come forward and present cases. Since you all know that we have a hybrid facility, anybody can present from anywhere. So you can contact me and then we can arrange that you can present cases from elsewhere also, right? Those who are in Mumbai, please come to Sion Hospital because physical interaction helps in better learning. Thank you. Meet once again next Thursday.